Hi everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. We're at the HIMSS 2022 conference and we're here with Rita Bowen. She's Vice President, Privacy, Compliance, and HIM Policy at MRO. Welcome, Rita.
Thank you, John. Always welcome to be back with you.
I know, you're one of my favorite people to interview, so it's great to have you here. So give us a little background on this patient right of access rule. I know you're an expert of it. People are trying to understand what's going on. It's relatively new and there's some confusion, on where this new rule resides. So give us a brief explainer.
Briefly, the patients have always had a right for their information, and it's a little concerning to me that it had to be taken so far to have issues with patient access, but they basically wanted to move toward having the patient control their own information and have ready access to it. Unfortunately, the interoperability rule hasn't come to full fruition yet. So there's the need often for facilities to either do it themselves or contract with a vendor to help them provide that information. So we're under guidelines to provide that information in 30 days. The rule requires that it's not just coming from the health record. If it's a patient request or a patient-directed request, it's going to come from the designated record set. And unfortunately, a lot of facilities have sort of lost touch with what that means. And it's basically any information that is used to care for the patient, to make a treatment plan, or to even pay the claim. So it's broader than the health record. So that's where we're seeing a lot of the confusion.
So let's talk about that. The designated record set feels like the next term that people need to understand, right? So what is the importance of really defining it? Because like most of the things we've seen with HIPAA, et cetera, right? You can often define what is the designated record set, similar to previously with release of information, right? You can kind of define what is the medical record,
Exactly, and I know I had the opportunity to speak with HHS and we were going through that, and I said, the designated record set is broader than the legal health record. And they said, what's the legal health record? And I went, well, the business record of the facility, which is the medical record. But the designated record set is not new. It was put forth when HIPAA came out 20 years ago, that there's a subset of information that's used for the patient's care and treatment that is not contained in that health record. And the patient or their directive should have a right to that if they so choose. For example, a fetal monitor strip is not interpreted. So since there's no interpretation of that in the health record, then the strip itself should be made available to the patient if they request it. So some of these patient access issues actually occurred because fetal monitor strips were not provided because people weren't going to that.
Interesting.
So, and then the issue has expanded because with the patient access being able to direct that access to a third party that's standing in the shoes to make decisions for healthcare for the patient, if they're directing it to that third party, it's the same as if I'm directing it to myself. So some of the issues that as I read the different fines that were given, sort of fall into several different buckets. One was because the privacy rules for substance abuse and other things that require special authorization doesn't apply for a patient or patient-directed request. So I use the example as if I'm crazy, I know I'm crazy. You're not informing me. I already know I'm crazy. So a lot of it is that people just don't understand the full breadth of the rule. And then when the interoperability rule comes out, or is out already, and we're supposed to be migrating in that path, we're under the US CDI, which is the United States Core Data Elements for Interoperability, version 1. But, people said, oh, that's your designated record set. No,
that's a very small subset.
That's a small subset. You got it. So there's still a lot of confusion in that term as to what should be in the electronic designated record set and just the paper if it still exists.
Well, and it feels like some people think, oh, well, I'll just give them access to the info in the EHR, but that's not the full designated record set, right?
Correct.
Yeah, so I think that's the interesting challenge in education there. How about you talked about some of the, enforcement that's happened around the patient right of access rules. There's been 30 plus enforcement actions, anywhere from $3,000 to $200,000 with with actually probably the more expensive part, the corrective action plans that they have
That
to
you
do.
have to stay on for a number of years.
Yeah, exactly. So what are some of the common reasons you're seeing, provider organizations being cited for this, and what trends are you seeing in the enforcement actions they're taking?
The trends I've already mentioned too. Applying restriction special authorizations when it should not apply, not actually using that designated record set definition to pull information from. Also, that people fail to recognize a patient representative that actually is legitimate. So, for example, a couple of the cases were adult patients, but they have issues that require that a person represent them.
Gotcha.
And so there was an adult child, the parent was the patient representative, and they said no, they're over 18, we can't do it. And so things of that nature. Then there's some that fall into the fact that you've got 30 days to respond, and 30 days is your outer limit. And you can have a 130-day extension, but those should be your exceptions. And so some requests have gone beyond that 30 days, and what I'm seeing as I'm looking at those, it's usually, unfortunately, a smaller facility that may not truly understand the time.
Yeah.
Sometimes it's a larger facility that may be trying to do it the release of information themselves, and
too much volume.
It's too much volume, and it's too spread out between campuses. So maybe these remote practices are having to upload information to go over to the main facility to actually. So when are they saying the clock runs? It's not when they upload it to them to start working on it. So if it's set over here for 2 weeks,
then you're at their mercy, and then it becomes a problem.
And and if it's a practice or a physician's services, the first and foremost is taking care of the patient.
Yeah, which makes sense.
It does.
Yeah, but it's hard, right? Because you don't want to get the fines or the corrective action plans.
Right.
So what steps do you recommend for hospitals and health systems to really take now to comply with the rule and avoid those plans?
Well, first thing I would suggest is know where the sources of release of information are occurring. Where does the patient or a true patient representative go to in your facility to ask for that information?
Okay.
I would suggest that you make a one-stop shop so that there's one place, and the patient, that person at that intake process understands the rules and that can facilitate that process rather than have them go into remote areas.
And is that always for the patients? How about like lawyers or other
Same
people that are
thing.
requesting? You think one-stop shop for anyone that's requesting anything?
And unfortunately, you're going to see a lot of attorneys that getting a patient to sign a patient directive.
Right.
And a patient can direct their information to anyone.
Exactly.
But with the Judge Matus decision, when the guidance was questioned, and there was a lawsuit a number of years ago by Ciox versus Azar, the judgment was, yes, the patient can direct to anyone, but unless it meets the definition of a patient representative, i.e. that person is standing in the shoes of the patient or representing the patient in a healthcare decision or payment of their claim or something related to that healthcare process, then that third party is still a third party and can be billed at the appropriate rates. That's where we're seeing a lot of abrasion and debate now in the
Well, they're
healthcare.
trying to bypass the cost.
Well, they want it for free.
It's easy to see why that happens. Interesting. The other complication to this, I think, is that we have state-specific consumer privacy laws that are coming into the picture. I'll speculate there may be a federal one.
I hope so.
A federal consumer something coming into the picture. But how would these impact the patient right of access rule?
I don't think, even if there's a federal rule, the patient access is going to be still paramount. It will be required, even in the notice of proposed rulemaking. It did not take anything away from that. It actually reduced the time, or suggests to reduce the time. It has not been published. I think in the plan it says that we may see the results of that rule finalized by late this year. And they're saying they want to propose to reduce the 30 days down to 15 days. So that, if anything, it will make it better for the patient.
Yeah, well, and when you think it's electronic, in many cases, you're like, is 15 doable, I guess is my question.
15 is very doable unless you have a lot of information that is in legacy systems and or information that you still have stored in other media that you have to go to and pull. That's where the problem comes in, but you could apply an extension to that. The whole interoperability rule, though, if they can make that patient availability to them through a portal or through an intake to their process, and they can download their own information, it sort of all goes away. All the debate about how long it takes, it's really in the patient's hands at that point.
Well, and that's interesting, because then they don't even have to request it, right? You avoid all these requests. You don't, free up HIM staff, which are overworked and probably don't have enough staff as is, right?
Yeah, and the same thing with attorneys. Then if the attorneys are saying, "Hey, I'm the directive," well, then fine. If you are and you want it for nothing, get the patient. No, they can't, but they can have their patient. Exactly. So the patient can download, and I've argued with attorneys on the phone. We'll get the patient to get it for you and see how useful that is, because there's still limited information that's on that portal. I mean, and you look at all that's required under interoperability right now is USCDI version 1. Version 2 is already there. They've got version 3 out for comment now. So that's the minimum at this point, and some still haven't achieved it.
Sure. Well, and it will continue to evolve. But I think, overarching looking at this, it's great to see us, like you said, finally empowering the patients to have access to the data.
Yeah, and it's hard for me because I'm a long-term health information management, been in it forever. And, I've always felt like I was empowered, but I do know that it's all about, if you know the system, I truly would not have any family member of mine go into a hospital at this point or go seek health care without someone with them that understands how the system works.
And how to access the information.
How to access and how to maneuver. I went with my niece recently. She had to have some shoulder surgery, and I was supposed to pick her up and take her to my house because I was the only one in the family that didn't have COVID. So I could take her home. And when I got there, she was having an asthma attack. I mean, and I'd never witnessed that. And I said, she's staying the night. I can't take her home like that. And they said, oh, well, okay. But I think they had given her, they put the pain block in, and they had blocked something, and it was causing the problem. So I kept asking. I said, she has a unique pulmonologist that has all of her records. Can you call them? And they said, he doesn't have privileges here. I said, I don't care. It's a community, so can you not at least call him? They wouldn't do it. I had to call him, and then I had to have him call back in, and I had to go find a nurse, and she said, I can't take those orders. He's not on the cell. I said, take the damn orders. And I said it like that. Take the orders now.
No, for sure. Well, and that's why we need to connect them to the
exactly,
right?
Because if there's a health exchange, then it doesn't matter what facility you have privileges at, the core information that will protect the patient. I know in one of the sessions I was at earlier this week, there was it was Jessica somebody, and it was the law that was passed in her name. She had an opioid abuse situation and finally gotten off of it, and she was going to have a procedure done, and she said, whatever you do, do not prescribe opioids. And she said, I want that in my record. Well, because that fell under the protected component, it didn't go to the HIE. So the HIE didn't see it, and then they actually ordered opioids, and she wound up dying. She killed herself because she got hooked again. And I thought, oh my gosh, when you tell a story of that magnitude, and it's just, there's just no need for the fact that siloed information needs to exist.
The data governance is so important, and being able to share it with the right people. Well, Rita, this is such an excellent interview. I love learning more about this, so thanks so much for sharing, and thanks everyone for watching. If you want to find more great health IT content like this, be sure to check it out at healthcareittoday.com, or also search for Healthcare IT Today on your favorite podcasting application. Thanks, Rita.
Thank you.